Thanks for coming today. I'm Dr. Michael Giles. I'm the CEO of Sonara Health, and I'm also a psychiatrist. So I started Sonara Health based off an experience I had in residency training where I got to work in an opioid treatment program. And it was a really unique practice setting in that most of my new patients were leaving treatment for seemingly healthy reasons. This requirement to come into the clinic made it difficult for patients to also pursue things like education, going to work, child care duties. And so I would advocate on behalf of these patients to the attending physician, can we get these patients more doses of take-home methadone? And rarely was I successful in convincing the attending, and it ultimately came down to an issue of patient-provider trust. Providers really wanted to have a good understanding of how patients were using their medication before giving them multiple doses of take-home methadone at a time. And so that's exactly what Sonara is. It's a platform designed specifically to build patient-provider trust around responsible medication handling behavior. It's a patented web-based application registered as a Class 1 medical device with the FDA, and it's hyper-accessible and works on any internet-connected device with a camera. And we built it around a forward-looking clinical workflow that enables providers to maximize the impact potential of SAMHSA's latest regulatory changes. And so here are some screenshots of how patients interact with Sonara. At a high level, patients are able to use their device as a virtual dosing window. The dosing process is recorded remotely onto our HIPAA-secure cloud backend, where providers can then watch the dose recordings at their own convenience and view the patient's history of medication adherence. So we have an exhibit booth 112 where anyone can come by and we'll walk you through how Sonara actually is for the patients and the providers, and you can even try it out yourself. So Sonara was launched at the end of 2022 after a phase 1 NIDA study showing excellent usability and acceptability among both patients and providers. These results were published in the Journal of Substance Abuse Treatment, and our phase 2 study examining the impact on non-emergency medical transportation costs is currently underway. We're in about 10 states now between Florida and Alaska, with over 2,000 patients onboarded and over 150,000 doses recorded, and of note, 0 notable safety events. So Sonara saves patients tons of time. 76% of patients enrolled in Sonara commute more than 15 minutes to the OTP, many relying on non-emergency medical transportation. The time saved on commuting to the OTP is a proven driver of retention and satisfaction. Some of our earlier clinics are now starting to see this in their cohorts. In terms of quality of life, patients reported more time for family, employment, and social activities. 62% of patients reported improved mental health through our approach to trust building. And if you think about it, this actually makes a lot of sense. From my psychiatrist perspective, one of the diagnostic criteria for a use disorder includes a pattern of opioid use that has led to damaged relationships and trust. And so by improving trust in the patients, we are directly addressing a key morbidity of the patient's use disorder. So the vast majority of patients are enrolled to Sonara to receive more access to take-homes. Patients are typically on Sonara for about 6 months before most providers have the confidence to prescribe 28 fully unmonitored take-home doses. However, one of the discoveries we had from our phase 1 study, which was funded by NIDA, was about 20% of patients wanted to continue using Sonara even though they were eligible to receive 28 unmonitored take-homes. And perhaps the most important question to me is, does Sonara actually allow for more take-homes? And the answer to that question is an emphatic yes. On average, Sonara patients receive roughly 3 times more take-home medication compared to before they were enrolled, and compared to patients who have been in treatment for a similar amount of time but aren't on Sonara. And so now I'm going to hand it to Chrissie Martin, National Medical Director at BHG, to discuss the really cool work they're doing in South Carolina.
Okay, appreciate the promotion, but I'm not medical. Not a doctor. I'm a national clinical director with Behavioral Health Group. I work primarily with our Midwest division, but Behavioral Health Group is a large provider. We have over 100 programs across 21 states and the District of Columbia. And we have 4 programs here in Nevada, including 3 right here in Las Vegas. If you're going on the program tours on Wednesday, which I encourage you to do, you'll get to see one of our programs here. But I'm actually based out of Charleston, South Carolina. So I'm here to share a little bit with you about what we're doing with Sonara back in South Carolina. Okay, so we have 3 treatment centers in South Carolina in Charleston, Aiken, and Spartanburg. Together we serve a little over 1,300 patients in those programs. And they're operating in some of the communities that have been most impacted by the opioid crisis in South Carolina. Aiken, Spartanburg, and Charleston counties were 3 of 8 counties that saw a greater than 20% increase in opioid-involved overdoses in 2020, kind of post-COVID. So certainly we've been very motivated to figure out how can we better serve the communities that we're operating in. How can we reach more individuals in need of our services? How can we retain them better once they've entered our care? And how can we make it easier for them to just get and stay in care? So we have some unique challenges in South Carolina as far as that is concerned. We're a non-Medicaid expansion state. So at our centers, less than 20% of our patient population are Medicaid beneficiaries. Even with grants, other payers, commercial Medicare, we have close to 50% of our patient population still paying out of pocket for services. And self-pay patients are harder to retain in care. So we have to think a lot more critically there about how to make treatment less burdensome to our patients. We also have quite a few rural programs in South Carolina that still don't have an opioid treatment program. We have some extra layers in South Carolina. We have border pharmacy involvement and some requirements that make it a little bit more costly to operate our South Carolina programs, and that makes it harder to go into smaller communities that can't support kind of a fully operating opioid treatment program. And so we've got 28 programs across the footprint in South Carolina, but still a lot of areas that are really underserved. So we really need models in South Carolina that allow for our OTPs that are in more urban areas to really extend their reach into these rural counties, something that's really important for our state. These were things that were certainly on my mind when the South Carolina abatement funds became available. I, like many of you, I'm sure, were kind of following what's going to happen in our state with these funds. Our state's about to get this big pot of money. What are they going to do with it? How are they going to kind of distribute it? So, we were really interested in how we could be involved in that. South Carolina has received $300 million in opioid abatement funds, and our legislature formed a board called the SCORF Board, the South Carolina Opioid Recovery Fund Board, to manage and disperse these funds. So the funds are divided into 2 subcategories. One is a political subdivision, which goes to the various counties and cities that were specifically outlined in the agreement. But then there's a discretionary fund, which is pretty much open to anyone. And that fund gets like anywhere from 15 to 50% of the funds, depending on how much the political subdivision ends up using. So when I was thinking about what we wanted to do, what kind of application do we want to put together for these funds, I knew that I wanted to do something that was going to help us, really extend the reach of our programs, that was going to help us retain patients, make treatment easier to obtain, and I was really interested in how could we use technology to really do that and to enhance our service delivery. And so I thought about Sonara. I had met the Sonara team at an AATOD meeting. I had their system had been demonstrated to me, and so I reached out to Dr. Giles and his team and said, hey, do you want to partner with us to apply for some funding to do this at our programs here in South Carolina? And so I am by no means a grant writer, but I still managed to kind of cobble together a proposal with a little help from the Sonara folks. And our technical proposal was basically comprised of a statement of need, outlining the need in the communities that we were serving, what the difficulties were with getting services into some of those surrounding counties, the difficulties around transportation costs for our patients, and how that was impacting patient retention, and how Sonara would really kind of help us to connect those needs. So the SCORF board really outlined very specific abatement strategies, so we had to connect it to the abatement strategy very carefully, and submit our budget, of course. And so we submitted our application in January of 2023. It wasn't until July that we found out the response, but we got approved. It was great. So our funding became available in October, and then once we got the funds, we were full steam ahead. So this is a picture from our enrollment day. This was at our office in Charleston. We had the Sonara team on site helping to get patients enrolled. And I kind of cut them off a little bit, but if you see the other table, the other person in the corner, Sonara also helped facilitate a partnership where we were able to provide free phones to patients that were enrolling in Sonara if they needed that access to that technology. And we've had a great response so far. So, you know, we're still pretty early, but we have 130 patients enrolled so far. Somewhere around 8,000 doses that were observed using the Sonara platform, which is really cool. I like to think of that as 8,000 fewer visits to the program that our patients have had to make just to get their medication. Most of our Sonara enrolled patients are getting 6 or more doses per week. And when we were thinking about what patients to enroll, you know, again, we really tried to target those that would be most at risk for premature discharge and had the most to benefit from that reduced attendance. So patients with those transportation barriers, but also patients that might not typically be eligible, that maybe didn't have the degree of clinical stability that we typically kind of look for when evaluating patients for take-homes, but that were really low risk for severe intoxication or diversion that really just needed that additional accountability or monitoring. So it's still early days, but signs are pointing to what we had hoped, that our Sonara enrolled patients are having better treatment retention rates than our kind of historical baseline. So we certainly hope to see this program continue to grow. We just applied for our project continuation funds back with the scoreboard, and fingers crossed. So now I'm going to pass it to Dave.
Good afternoon, everyone. My name is Dave Kneessy. I'm the Regional Director for Central Florida Treatment Centers, and I got to say, sitting there watching her run 2 slideshows at once, I have ADD, so I'm like, I will not be doing that. I have paper. So at the risk of, which one, forward? At the risk of, my boss told me, quit putting so many words on the slides, make them shorter. You see how well I follow directions. So at the risk of mentioning something controversial you may not have heard at this conference, our field is changing. So part of the good news is we're beginning to change regulatorily to focus on patients having a medical condition and medication being part of medical treatment for a medical condition. That's the good news. The bad news is we have to balance that in our OTPs with patient safety. We've got to manage the safety of our patients because while it's new to us, and I don't know about you, but when I first read the SEARHC, I was like, how are we going to do this? Imagine what the patients are going to react to when things change this dramatically. So the other piece we need to remember is that patients do from time to time struggle with adherence, struggle with managing their behaviors outside of a clinical setting. So we need to take that all into account. But in the effort of treating our patients with respect, humanity, and dignity in what we're doing, we need to balance that with regulations. So you've probably all run up against state regulations, federal regulations, other regulations that prevent patients getting what just makes sense as far as take-homes. The other thing that we didn't really think about was the ability to have real-time monitoring of medications. So we're able to see things that we might not ordinarily see. We might not even ordinarily see with the nurse at the dosing window, because when you got a long line and you've got bottles lined up and you've got patients coming and everyone's like, hurry up. So the thing now is we can go through and we can review that. We can have a nurse review that. We can have a clinician review that. We can go, what was that? And we can go in and look. And it's created some very productive discussions with our patients. So I'm just going to put that on there. So Central Florida Treatment Centers, who I work for, we've been doing this about 40 years. We specialize in MOUD. We started doing this when it was just called methadone maintenance, then it was called MAT, now it's MOUD. So we have all sorts of new acronyms to learn and get used to. But we've always looked at how do we innovate? How do we do things creatively to meet the needs of our patients? If all our patients needed was a counseling session and medication, this would be an easy thing to do. Those patients are few and far between and rare. Our patients have a myriad of significant chronic needs that we need to address. So just as an example, we're always looking to innovate. We're looking to incorporate mental health counseling in our OTPs because our patients need it. It's a battle to get them served in the community in some communities. And sometimes mental health care providers with the best of intentions work against us. So that's just an example of where we're trying to innovate and come up with solutions that work for our patients so that we can provide the most respectful, humane medical solution that we can for our patients. So our path to Sonara was a little easier than Chrissie's. Our managing entity, for those of you that don't know, in Florida, federal money goes to the state money goes to regional managing entities, and then it gets parsed out from there. Our managing entity in our northern region, Central Florida Cares, approached us and said, hey, we're interested in this. We'll fund it. Will you do a pilot and give us the data? We're like, you're paying for it? We're in. No problem. So that was our no grant writing, any of that. It was just done and done. So we began meeting with Sonara. And the good news is it wasn't we're going to come in tomorrow and start doing this with your patients. There was a whole build-up. There were technical meetings. And what they really showed us was it is a cutting-edge, asynchronous monitoring of dosing. It's hard for those of us that have been doing this for a while to get out of but if I can't see them, how do I know what's going on? So this is using technology to do monitoring of many, many more people with less time at the window. The other thing that we began to figure out was it was empowering our patients. So most of the rest of mine, and I will tell you if you see a testimonial, read it yourself. I'm not going to read it to you. That makes me crazy. But a lot of what our patients are telling us are the things that we were surprised by. And as an example, the first person up there, Emma, our clinical supervisor in the program, started out with, I don't know about this. This doesn't seem appropriate. Maybe we shouldn't be doing it. What do you mean we're going to give patients take-homes who don't meet the criteria for take-homes? She's now our biggest advocate. She is like, put more people on, do more of this. Basically, what she said is once we got through the initial stress with the patients and how do we make it work, she said this has become crucial. This has saved patients' treatments. This has kept patients in treatment who would not otherwise be able to be in treatment. So it's been a huge shift for her. So what we found, we've been in it not quite 6 months, and we're doing it in one clinic, although we're now ready to try to expand it into some more clinics. We found that there's enhanced privacy. One of the things that occurred to me as we've been talking about all the stigma of the care and stigma attached to our patients, can you think of any other medication that you have to go line up in a lobby or the porch or down the sidewalk and stand in line for 20, 30, 40, 50 minutes in some cases to get that medication? This is the only medication we do this way. So we have an enhanced privacy. We have an enhanced respect that comes from it. We're also getting better adherence because we're getting real-time feedback. So when we go in and we look at the dosing video, what we see, if there's something questionable, we don't, oh, you're off, you're out. We have the patient come in, we meet with them. We saw this, can you tell us about this? So we've had a number of patients where we've had to have some meetings, we've had to have some discussions, we've done a little bit of contracting. But what we found out is 98% of our patients have achieved adherence and compliance to where we're getting all green reports, so they're doing very well. The other thing we were able to do is have an earlier intervention in some instances. We had some patients that were having problems. Rather than waiting till they came back, waiting till they came to the clinic, waiting till they missed doses, we were able to intervene very quickly, preventing situations from getting worse. We're also hoping to have more data-driven results as we get more of this done, getting more numbers, as Chrissie was able to talk about. So some of the testimonials that I want to touch on, these are just patients in our clinics. Alexandria, and this has happened to all of us. She moved to a different county. She didn't want to go to another clinic. She liked her clinic, she liked her counselor, she didn't want to change and go through the whole redoing everything again. How many of you travel further to go to a PCP or an MD that you like than one in your area? So she was able to do that because of Sonara. The second testimonial here, Brad, we have an aging population. We're getting more and more of them. And part of what he was talking about was just being able to do this more at home, maintain my sobriety. For him, the more time at the clinic, the more time in the parking lot atmosphere, the more time in the stigma it wasn't preventing him from being in recovery, but it was impacting the recovery. So he said this is an aid to his being in recovery. Robert was a very unique example. This is another older patient of ours who basically his wife, they live outside Orlando, his wife works in Orlando. She was getting up, getting him, driving him to the clinic, waiting at the clinic. He'd come in and dose, do counseling, drug screening, whatever he needs to do. Get back in the car, she would drive him back to their home, then she'd turn around and drive back into Orlando. 5 days a week. So again, this was a blessing not only for Robert, but for his wife. He said his wife's stress level has gone down so far. He's able to manage coming to the clinic. This is much less stress. Doing it once is not a big deal for her. They've had much better conversations because she's not all stressed about getting to work. So this has been a huge blessing for both of them. The last one I want to touch on is we all have patients in our programs who their work schedule does not work with our schedule, plain and simple. And part of recovery is going to work every day, paying your bills every day, living life like all the rest of us. So basically what James told us about was his treatment was basically getting to the point where he was going to have to drop out and stop coming to treatment because he was late to work. He's an operations manager. His days start early. He couldn't get to the job on time, so he was in danger. It was causing work problems. We must, in this field, do nothing that harms our patients. We're trying to create for our patients a more recovery, more calm, more normal lifestyle. What we've unfortunately done because of things like regulations, because of things like standards, because of things like oversight, is we've made it harder for our patients to live that recovery lifestyle. So the neat thing about Sonara is it is a tool. It's just a tool. It's not a silver bullet. It's not a cure-all. Whoa. It's not a cure-all. It's not a fix. But it is a tool that helps us do that as we move more towards treating patients like patients, not those people. So next I'd like to introduce Dr. Corey Cox. He is the clinical director in addiction medicine for Southeast Alaska Regional Health Consortium. Read that tiny print. So.
Thank you guys so much for being here today. So yeah, my topic is opiate use disorder in the 49th state and how we have used Sonara to really build a safe and effective treatment platform for patients in a really challenging place to deliver care, especially with all the requirements that kind of go into building and maintaining and certifying opioid treatment programs. So this is kind of a map of the southeast general region of Alaska in 2021. So Anchorage is in this little bay area here, and if you go down the coast, you get to Washington and Seattle. So in 2021, there were 3 opioid treatment programs in Alaska. 2 of them were in the Anchorage area, and 1 was in the Matsu area, which is really close to Anchorage. So this leaves our whole region of care where I work without any opioid treatment programs. So to give you a sense of scale about this, I have this slide, which has a scaled picture of Florida. So the Alaska Panhandle, just the little part that dangles down of Alaska, is about the size of the state of Florida, and we have about 80,000 people there, and no road system. So you can imagine it's a really challenging weather, lots of rain, lots of snow. So it's a very challenging place to deliver any kind of medical care, but particularly opioid treatment programs. So a place that you have to go to this clinic every day and get your medication. So how does this, how do we adapt that model to, delivering care in an area that really needs it, because our overdose rates are rising and we have lots of patients that really need this medication option. So in 2021, we opened our first clinic in downtown Juneau, Alaska. So that's the capital. It's in the panhandle here. We have about 30,000 people here. It's a reasonable place to start an opioid treatment program. It's in a great central location at an FQHC. We opened in February of 2022. We have over 100 patients now, maybe 120. That community made sense to have a traditional opioid treatment program model. But this was our largest community in Southeast Alaska. This is kind of a picture of some of our inside of our program. We're very proud of it. This is one of our nurses at the medicating window. So yeah, the program was really successful. We had a lot of patients that entered into recovery from their opiate use disorder. We got a lot of great feedback from the community and people. And then kind of talked to our board, and they were like, how do we deliver this care to the rest of Southeast Alaska? So we kind of opened in a hub and spoke model, with Juneau kind of being our mothership, and then having very small but independently, fully certified opioid treatment programs in other communities. Our first program was in Sitka, Alaska, which is the second largest population center in our area. And then we opened a third opioid treatment program in Kwalak, which is on Prince of Wales Island, which is an island that has about a population of 5,000 people. We're working on opioid treatment programs in Ketchikan, which is an area that's outside of SEARHC's area, but a decently sized community. And then looking at maybe putting some med units in some other areas to serve some other remote communities. But it kind of begs this question of, this is another map of Southeast Alaska. The 2 stars are our opioid treatment programs, or 3 stars are our opioid treatment programs. And then the red areas are all communities that are served by SEARHC. So these are all places that have people with opiate use disorder. They're all places that, have people that are struggling with this addiction and really could use this medication treatment, this option, and deserve to have, equal care to anybody in any other place. Like everyone, no matter where you live, really, you deserve to get the medical care that you need. So it kind of begs this question of we can keep opening opioid treatment programs, but the smaller and smaller communities, the more difficult it is to open a full opioid treatment program, even a med unit, to staff it and make it worthwhile. There gets to be this point where it's just difficult to do. So, how are we going to deliver care in a place like Cape, or a place like Pelican, or a place like, all of these communities that we serve that we can't get? And then what about our patients that are, moving around Southeast Alaska? What about our patients that go out fishing? What treatment options are available to them? So yeah, people who live in smaller communities, people who have inconsistent access to transportation, people that live in remote areas without road access. We have patients that come into our opioid treatment programs that have to fly to the treatment program every day. There's no way, there's no road to get there. So if they had to come in every day, you can see how that's not feasible for someone to come every day. So how do we manage this risk of, giving someone in early recovery a medication that's potentially dangerous, that a person I don't know very well, and I don't want to instill extra harms into this person or their life or their community. So to provide them some framework and some accountability, but also give them access to this life-saving treatment. So yeah, like I said, as communities get smaller, barriers get a lot bigger. Cost per patient increase because there's a minimum number of staff that you have to have for an opioid treatment program. You have to have a medicating nurse. You have to have someone to relieve that person, when they're out on vacation or leave. And our patient load just decreases and decreases in smaller communities just because there's fewer people. Community stigma increases a lot. People really, the smaller the community, the less they want to be seen going in and out of an opioid treatment program. Clinics are more difficult to staff and manage. You can imagine, I know everyone in here struggling with staffing with their opioid treatment programs. Imagine trying to find qualified people to come to these really tiny communities in this place with terrible weather and really, really difficult places to live sometimes if you have to have So, it requires some creative problem solving. So, we've talked about med units in places. We've talked about providing, we provide transportation to patients to and from clinics. But one of the really key things that have really helped us deliver this care is the implementation of Sonora and remote and asynchronous medicating. So I think it's really allowed us to expand treatment throughout in communities in Southeast that I would have said, 10 years ago, it's just impossible to deliver care with methadone in our current framework. Really, it gives us this opportunity to build an accountability system with patients to where I feel like I can comfortably and safely give them this medication and give them, adequate titrating instructions and have them, be able to use their medication responsibly and ensure that we use their medication responsibly. I can't say how many times that, we've had that just our doing Sonora with patients has prompted, difficult conversations with patients who are doing really well and then, they're not uploading the video. And, years ago we would have, they came back into the clinic, everyone would have just said, they took all their medications. But this gives us this extra layer of, accountability and ability to have these conversations with patients, which we wouldn't have normally had that window into their life. So, as a lot of our other speakers came from this position of like, we really want to make it easier for our patients to come into treatment. I think we came at this from like, how are we going to deliver care in this really difficult environment? And, how can we make this feasible at all for a lot of our patients? So it really eliminates the need for daily commute to the clinic for a lot of our patients. We've kind of structured our titrating plans and our initiations to have patients not ever have to come to clinic every day, which has made it feasible for patients who live in remote communities that have to fly into the clinic to come in and get medications. And it really gives us the flexibility to adapt to all these different communities. Like every community in Southeast is different. They have different histories, and they have different needs as to how they need their program to look. And this really gives us a way to implement it and it be different in every community, but still be supportive and still be a safe way to give them medications. So, I think we've really made up for it in patient retention, and our patient feedback has been really excellent, and I think we have multiple patients in multiple different communities that this wouldn't have been feasible, or they wouldn't still be in treatment if it wasn't for this platform.
Yeah, let's talk about 2024. Some really cool things will be coming out. So our measurement-based care platform will help track patients' recovery progress using known clinical benchmarks. This will be particularly interesting in value-based care arrangements. One of the other cool things is that there's a lot of operational freedom with the new regulation guidelines, and we enable providers to measure and benchmark various clinical workflows and policies to drive patient impact maximally. And to that end, we'll be launching a measurement-based care really whole tool suite to do exactly that. And then two-way messaging is a widely requested feature, and that's going to launch very soon, the next month. This will help drive patient engagement further and supports the more than medication approach to driving recovery success. And then the last feature that we're really excited about is soon we're going to directly facilitate remote intakes and counseling. And so we designed this virtual intake and counseling workflow around SAMHSA's latest guidelines to really dramatically increase treatment access and feasibility for patients.